O&L perpendicular to the IR.
Okay, I'm pretty sure we wiped all the COVID
Isn't that the eye to the ear?
off of that board.
Isn't the O&L the eye to the ear?
Yes. Okay, the M stands for meatus, and it's always talking about the auditory meatus. And so the OML is it's actually easier to look at the, like this crease right here, which is called the outer canthus, and just line that up.
Okay, so is that good? Like,
Well, I'm going to have to take your word for it.
well, I'm just talking about if that's straight, because
Let me see.
I know it's not lined up. Sorry.
That was so loud.
Sorry.
You're gonna PA.
All right, so we're going to put an image receptor in there. Yes, okay, for our first trick, PA skull.
Up just a little bit. Like right there?
Isn't it like that?
Step off just a second.
Okay, yeah, that.
Okay, right. Yeah, that actually looks pretty good. Usually, if you get the patient's forehead and nose against the board, that usually puts them approximately, and then you might have to tilt them up or down just a little bit.
Okay. So then you center. Where is it center? Exit.
All right.
Well, that's about right anyway, ain't it? The exit point, or go down just a little bit.
Okay, we need to go down just a touch. We're supposed to be exiting the glabella, right?
Yeah.
Okay, that's going to be like just above her eyebrows.
Okay.
Yeah, I mean, you're real close.
I feel like I'm really swaying.
You probably are. Here, ma'am, hang on to this. There you go.
What? What happened there? I told her. She said she was swaying. So she goes.
Are they done?
Okay.
Oh, my bad. I was like, they.
Now
I
for.
was like. Okay.
Okay, the thing about skull x-rays is, especially if you're doing them, now sometimes we do trauma and we'll do like AP skull. We don't do that unless we absolutely have to. And do you guys know why?
Because it causes magnification.
Well, okay, the main reason is because the lenses of the eye are very sensitive to radiation. And so we would prefer not to, shoot the patient in the face with an x-ray beam.
Why won't it go up anymore? Oh, because it knows there's a 10 by 12 in there or something?
Oh, yeah, apparently so. Okay, well, the reason I'm happy is because this thing wasn't working up until recently.
There it
The
goes.
two?
No, the PBL.
Oh. What's the PBL?
Positive beam limitation.
So then that's it? You just put your marker?
Yeah,
I'm sorry.
something's not right here. There we go. Okay, now, whenever you're doing skull x-rays, your finished product, it doesn't have to look like a pirate skull, like with the complete mandible and everything. When we're doing skull x-rays, we are only interested in the brain case. So we're totally allowed to cone down.
Case?
The brain case, yes, that's the part of your head that contains your brain. Okay, now, so we can cone down some. Not a whole lot on this particular patient, because what we don't want to do, see how the top of her head is included in the light field? Yeah, if we cut off the calvaria, which is like the very top of the skull, then we have to reshoot. If we cut off the base of the skull, then we have to reshoot. If we clip off the mandible, no problem, because we're not out after that on this particular image. Now, this patient has a pretty small head, so we're not going to have any problem getting her all on one 10 by 12.
I could really fall asleep like this, y'all.
You look so unbelievably uncomfortable.
That's because you stayed up too late.
Okay.
Does look guilty.
So then you just put a caudal angle on it for the 15 degree and then you just line it back up the same way?
Okay, now, you're talking about for the Caldwell.
That one exits.
Okay, now,
A little.
this exactly. Okay, now, and if you think about it, it makes sense. Because like Ms. Mia was saying, now we're going to put a 15-degree caudal angle on the tube. Well, obviously we can't exit the same place anymore. because we're angled.
Yes.
So now we're going to be exiting at what's called the nasion.
No, like.
Exactly. We're going to exit the nasion. So bring your image receptor down, down, down.
Put your forehead on it.
Okay, I wasn't totally off.
Alright, now you can fix your forehead, cause that. Yeah.
Don't know my back.
I like the third.
Okay, so now we're just going to put a little down angle on. Okay, that's 20 degrees.
Yeah.
So this is your collimation is really gonna affect our light.
Yeah, you go, girl.
Yeah, like how often do you see this? Is my
I've not seen it.
Like, yeah.
I seen one yesterday, well, that's for the sinuses I seen yesterday.
Really? How ironic.
Because you're at Wilmington Health.
No, I'm not on.
Myrtle Grove.
That thing, yeah.
They do a lot of sciences.
They do.
I've been there like a lot.
I'll say I've been there. I got what, 2 more days there or whatever, and I've only seen one. It's been slow there.
Well, some sites are definitely busier than others.
Y'all gotta let me know y'all take that thing out. It's so loud right here when your forehead's on.
Okay, now my patient's OML is not exactly. Sorry.
Okay.
There you go. Much improved.
Thank you.
All right, now lean forward and touch your head against the COVID board.
What's the hit it down or the all three?
Are we good?
Okay.
Okay, now once again, we're open to film size, but we can totally cone down for this patient because, you know, again, her head's not that big. We just don't want to cone down too much because we don't want to clip anything.
Man, I mean, just.
Especially, but if it projects low, you want to make sure you get at least some of the neck, right? Since it's an angled piece.
I think she said that. I mean, because
You don't.
still don't need the man.
No, you don't, and you certainly don't need a C-spine.
Yeah. I'm just worried that I would cut off because it's pushing everything down.
Yeah, exactly. It's going to be
I
good.
feel so out of the loop because I don't know what's happening behind me.
Trust us. It's all good.
Alright.
Okay, now for our next trick. What's
30
going?
degrees.
30-degree caudal angle. Okay, this one. Some people refer to this as a 30-degree Caldwell.
Yeah.
It's really it is a PA axial. With the 30-degree angle, it's technically
You're good.
not a Caldwell, but I mean you can call it that. Okay, now here's an issue. Wonder if we had a patient that was like 6'2", and we were trying to do this.
Still.
Exactly. Very good. We would put them on a chair, and that way
I feel single.
we don't have to reach up to the ceiling.
Okay, you tell me how awesome that would look. You're sitting in a chair.
Okay, now where's our exit point for this one?
Gymnasium.
We're still at the nasion?
Yeah.
Okay.
This one's funny. It
Yeah.
looks like a little water creature. Small head.
Okay, there we go. So now
I have big head.
we've got much more angulation. And actually, I think we may have too much angle.
I'm gonna ask her that too. 'Cause I don't want to be like, ooh.
Okay, right there goes a 30-degree angle.
No, I'm gonna
I'm listening to you, Michelle.
There you go. Okay, just come over there. There you go. Okay, now we're centered up. That's a little bit better.
I was going to move this down, I don't know where it's at.
It's right here. All right, hold still now.
You can ask.
All right, Ms. Mia, what do you think about this?
Ready?
It's mighty what?
Lady, close to your top of your head.
Yes, it is. Hey,
Sorry.
quit moving.
Sorry,
Yeah,
sorry.
that would make me so
Quit moving around.
I feel like
He's patient, man.
it's difficult.
You're making our job difficult.
You can see how oblong her,
Oblong.
oblong shadow of her head is.
Yeah.
True.
Am I pronouncing it wrong?
No,
I don't
you're
know. It's just
pronouncing
the
it
way you
right.
said it. Oblong.
Oblong, oblong. But it looks like an egg.
The oblong noggin.
Can I go to the bathroom real quick? Yeah, that's the thing.
Okay.
Like, okay.
I'm just going to kind of zoom in on the board here a little bit. All right. Let there be light. Okay, now, trying to get this patient lateral is going to be tough because
Why did you stress that so much when we were on the PowerPoint?
his shoulder's in the way. All right, Ms. Mia, look straight at me. I know that's not
weird.
easy to do. What I'm going to do is I'm going to go about 2 inches above her EAM, and I'm going to turn you this way just a little bit. And I'm also going to get you to tilt your head towards that board. There, whoa, whoa. That's enough. That's enough. That's good right there. Because not only do I need her head to be lateral, but I need it to be true lateral. In other words, it's got to be not rotated and not tilted. Okay, now if I've got those two things, then I'm going to be golden. Okay. Now then, ma'am, I'm going to get you to take just a little shuffle step forward for me. Towards me. There you go. All right. So there I am. I'm like about 2 inches above the EAM. And I'm just going to cone down to the size of her skull. And just double check and make sure. Ma'am, tilt the top of your head towards that board just a little bit. There you go. All right, much improved.
So you have to get real close.
All right, now you have to face the patient because you want that interpupillary line to be level. And if you're standing off to the side somewhere, you'll never see it. All right, that looks pretty good. Okay, ma'am, can you hold that pose for me? Let me put my marker on here. All right, now hold still.
Can I go?
Yes, you may. Get going.
I gotta go.
He said, can I go?
Sorry. Here and here. And you got them, I think it doesn't. The next one.
Yep, well,
The town.
Or
Isn't it
whatever.
called towns? Plural?
town view?
Or
Like towns
I want to say
possessive?
town, but it's not. Okay, whatever.
I don't
Every
know.
tech that I talk to, they're like towns. Has to do with
Towns.
So maybe they're just calling it.
Okay.
Well, the dude's name was Towne.
Okay.
So I guess you
Yeah.
could, you could use
Either
the
or,
possessive
yeah.
form.
I don't even know if this
Say,
is
because this is Dr. Town's view. Or you could just say town view of the skull.
This is my town.
Sorry.
Trying to get me.
Trying to get a trash can.
This town is our
Hand on
town.
my trash can.
So much above.
Right, looks like we're doing.
We're going to attempt to do a town view.
Which one was the one blind you? Okay.
Okay, where's our entry point for this town view of the skull?
2.5 inches above the,
Glabella.
yeah,
Yeah, so basically it's going to be like right below the patient's hairline normally.
right
So
here.
you're pretty close.
Yeah, that's good.
I must keep it to the right.
Whoa.
Way too much. Oh, right there. It's okay.
Okay,
Can you go
now,
up more?
yes ma'am, you got a 30-degree angle on there.
Now, what line is perpendicular to the image?
The OML,
Orbitomeatal line.
the orbitomeatal line, exactly. So what you can do is you can look at the outer canthus and line it up with the EAM.
That's good. I thought it still needs to go higher.
Now it does, yeah.
Yep.
Yeah.
There you go.
Okay.
Thank you, patient. It's like you know what's going on.
All right, now, now how does our centering line look?
Low again.
Because we're way low, aren't we?
We are. What is that?
I don't know.
Kathy, you keep moving.
I did, I moved to the bucket.
She did move to the Bucky. Our OID changed our central
Okay.
location.
Scoot to your right, so
There you go. That's better.
Mm-hmm.
Okay, now we just need to bring our Bucky up to match.
oh gosh.
Okay, now once we take this image, how do we know if we had it positioned correctly?
You can see the saddle, or
The dorsum.
the dorsal.
Exactly. The dorsum is going to be located in the foramen magnum if this thing is positioned right.
So it's entering 2.5 inches above the glabella,
Correct.
right?
Okay, we may be a little bit higher than that, but, you know,
It's okay.
but I think we're fine.
I got a
Yes.
big forehead. It's an OG veteran.
OML is perpendicular to the IR.
Mm-hmm.
Correct. Now,
So
what
that's
if the...
outer campus and like
Yes,
Yeah.
and the, yeah,
meatus?
the auditory meatus.
Yep.
Okay, now what if our patient can't do all that? If all, like we start tilting their head down and all they can do is get to where the EAM is level with the inferior orbital line.
You do 37 degrees.
Yep.
Yes, we make up the difference with angulation.
Key.
Where were you on the 9 to the 15? So, let's see. That would be,
That's going to be a radical angle. It's going to be like on that indicator right there, it's going to be 53 instead of 60. An additional 7 degrees.
53.
Yes, ma'am. Yeah, hit that green button and angle down.
Are we doing 37?
Uh-huh.
Yeah, from 90.
Oh.
Yeah. 90 minus 37 is
53.
very good. All right, 55. I guess that's close enough.
just trying to think of it, so this right here, or this right here.
All right, now push it up, Miss Hope. Up.
Man,
Up. There you go.
SID, right?
All
Can you
right,
imagine if I was
Yeah.
standing?
patient, could you move over to your right just a tiny bit? There you
That's
go.
it. That's it.
Perfect.
That's the most perfect you've been
Perfection.
centered.
Our patient keeps slouching off to the left.
Okay, that's good. We're
That's
lined up
beautiful.
with our image receptor. Now,
Yep.
we just need to collimate inside to side, right?
Exactly. We can collimate down some, not a whole lot, because we don't want to we don't want to cut off the top of the skull.
Says the mandible can be cut off.
Mandible can be cut off, that's not a problem.
See?
Top of the
I don't
skull
know.
cannot be cut off.
Right.
There you go, that's close
good.
enough. All right, very good. 37 degree town skull.
Yeah.
Towns.
Thomas.
Okay, now, for a trauma view of the skull, the first thing we have to know is that our patient is traumatized. That means they're probably not able to stand up. Okay, should we ever do skull x-rays without using a grid?
Probably not.
Probably not.
It's definitely more than 10 centimeters.
Yeah, and we're always using at least 80 kVp, if not more.
Yeah, there's a lot of bone to get through.
Exactly.
10 by 12 lengthwise.
Do, 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 do. Okay.
Should I slip down a little bit?
Yeah.
But I use.
Oh, the question is, can I have pillows?
Maybe. Okay, let's take a look at All right, patient, you're traumatized. You're not supposed to be moving around too much. Okay, now let's take a look from the side and see if okay, now, these pillows, you should not do x-rays with the patient on top of pillows. How come? Well, because those dang pillows will show up on the x-ray, exactly,
Yep.
and they're gonna throw an artifact that's gonna look really weird.
As an area of,
Okay, but for purposes of practicing, we're gonna let our patient be nice and comfortable as much as possible. Now, okay, if I get down and take a knee here, am I going to be able to line up her OML? Can I see that her OML is perpendicular to the table?
yeah,
It is.
it is.
It is. Okay.
Good job.
Sorry, I'm just going to poke you in the eye.
Okay.
Actually, I think you need to tilt your chin down just a bitty bit. There you go.
What, isn't she
Yeah, now we're talking.
traumatized, so she can't.
Okay, now if your patient is traumatized and they're like in a C-spine collar and they cannot move their neck at all, then we can make up the difference with tube angle. We just have to angle our tube so that it's parallel with that OML. So, and then, you know, it doesn't matter what position the patient's in.
Entering the glabella.
Yep, exactly. Okay, whereas before,
That's where I
okay,
can
Miss
do it.
Kathy. Oh, you've got good leg muscles. Sorry, Miss Kathy. What I'm going to do is I'm just going to pull you down towards me a little bit, okay? And Mr. Ben's going to follow us with the pillows. So here we go. Oh, okay. Oops, I pulled you down a little too far.
It's all right. I still got it.
It's all right. There we go.
Right there.
Yep.
Okay. Entering the glabella, petrous ridges are filling the orbital, entire skull cranium should be seen without any cutoff. We can cut off the mandible, which we are
Yes.
doing.
We can cut off the mandible, but not the top of the skull.
Right, so we got that. So then we need to line this guy up. That's good. 10 by 12. Alright, so what's some things I can
Okay.
fix here?
17? Okay.
I can't do that. Alright.
Okay, for some reason our PVL's not working in the table, Bucky, so we're just going to have to do it manually. Okay, so if we shrink this field size down to 10 by 12, which we basically have now. Okay, now have we got her whole skull?
Nope.
Not really. Okay, so ordinarily we're going to aim for the glabella,
Yep.
but in this case we're going to go just a little bit higher. We have to.
Okay.
Okay, now we have light above the skull because, okay, it's kind of deceiving because a lot of this is hair, not
Yep.
skull. Okay, much improved. Now, are we a little bit above the glabella?
Yes.
Slightly. Yes, we are. That's okay. You know, it's better to have our centering point off a little bit than to cut off any anatomy.
Gotcha. Okay. So, and then the marker would go the right.
Yeah, you can mark right or left. I would mark right because you don't want to risk your marker getting lost in the bucket.
Yep. Okay.
No, so I did that.
Not that we know anything about that.
All right. Don't breathe. Don't move. Beep.
Exposure is known.
There's two
Please
kinds
not
of
move.
techs.
She
There's
sees it.
those that have lost their marker in the bucky
Yeah.
and those that haven't actually started taking x-rays yet.
Yeah.
That's right.
Mine is definitely lost at 16th Street.
Yeah.
Usually you can dig it out of there with a ruler or something.
Yeah, it's back there. It's like
Okay.
right here.
So you guys have already gone through the PA.
Right here.
Okay, now we're going to set up for a Haas view of the skull. This is basically a reverse town view. We're going to be using a 30-degree. Okay, my patient's going crazy. We're going to use a 30-degree cephalic angle instead of a 30-degree caudal angle.
So,
But the patient's OML is still going to be perpendicular to the image receptor.
So it's going to be 115.
120.
centering is the same.
Yes. Only this time we're not going to be entering 2 inches above the
Exit.
glabella. We're going to be exiting 2 inches above the glabella.
Ah.
Excellent. Easter joke, sorry. Alright. I'm a little ahead of schedule there. Alright.
There used to be a villain on Batman that made egg jokes constantly.
I like egg jokes. Okay, so
Is my OML perpendicular to the image receptor?
We don't know because we can't see over there. Yeah, you need to tilt your head forward some. There you go.
40 inch SID.
Much improved.
Much improved, he says.
Jerky jerky.
Okay, now in the book it shows this being done on the table, but you know, you could either lay your patient face down on the table, or you can put them put their face against the image receptor at the wall stand.
Alright, so this looks a little,
Wonky?
yeah. Okay.
We have a minor problem,
My height.
and I'm not sure if we can do anything about this or not. No, it's not your height. It's this chest stand. Ha, okay, sweet. I figured as much. Okay, so, sir, if you wouldn't mind, there you go. Just put your forehead against that image receptor.
Okay.
Perfect.
Forehead and nose, yeah.
And now I'm going to bring this down to about 2.5 inches above the glabella. And now we'll take our, is this thing right?
I'm not sure. It looks a little, there we go.
There it goes.
That's
See,
an angle
this
to it.
sometimes this thing comes out of, like the pivot is messed up. And so it looks like it's in detent when it's really not. There you go. That's better. Okay, now let's bring that thing down because we want our image receptor. Whoop.
So I was told to line it up with that. Not the actual board.
Uh-huh.
Yeah. Okay.
Exactly.
So,
Okay, now-
But then that brings this down here. So
It
it's
does,
like
and look, his
head's getting cut
his
off.
head's getting cut off. We can't have that. All right, sir, just relax. I'm gonna bring this up a little bit.
This one's kind of a tough one, I guess.
Okay, bring it on up to match.
Raw.
There you go.
Okay.
Okay, now with my patient's head against the image receptor.
Yeah.
Sorry about that. Okay, so
Okay.
now we're good.
Exits about 1.5 above the nasion.
Oh, at least.
Easy on.
If we try to go down that far, we're gonna definitely clip off the top of his skull.
Okay, so but looking back here, what can I
Nothing.
do to?
There's really no good landmarks on the back of the patient's head.
Okay.
You know, it's
So-
just, it's like trying to aim at a softball.
I'm paying attention to this as where it's exiting. is to
Exactly.
know where.
We want our exit point. And the other thing we need to pay attention to is the shadow of the patient's skull.
Okay.
Okay, that's gotta be on there.
right.
Now, that's gonna be close. Let's shoot it and see what happens.
Beep. All right.
Oh, clipped.
And then marker is gonna be here, maybe?
Yes. You can put a right marker on here.
Okay.
My gosh, am I really this tall? Nice.
Yeah.
All right, so
Oh man,
that,
okay, this chest stand goes up way high.
Yeah, it does.
If we had Andre the Giant in here, I'll bet we could x-ray his chest without putting him on a stool.
Probably not.
rest in peace. All right, so that's the IIS.
The Haas.
Check this out. Isn't this cool?
Very. I've got one just like it.
Do you really?
Yeah, Miss Berger.
Oh.
Block that.
All the coworkers at the orthopedic hospital are like, that is freaking awesome. And
Yeah.
I'm like, Miss Berger. I
It
was
is.
like, Miss
How
Berger.
was the tape? Is it okay?
Yeah, that's not
Yeah.
bad.
It's not bad?
I like the clear stuff. Clear stuff's working pretty
Well, I
good.
bought it and I didn't know, so
Yeah.
anybody can try the clear stuff. You don't like it, use the cutting.
Okay, now, are we gonna make our
AP.
patients stand up for this?
We don't have to.
Okay,
But
should our patient
It
be
looks like
sitting
they
down?
it looks like they are standing.
I don't know, I can't see
So-
their feet in that picture.
Take a little baby step forward for me. Now,
Okay.
look up at the sky.
We'll try it both ways. We'll try it
with
with the
your whole
patient
head.
standing,
There,
and we'll try it with the patient sitting down.
There you go. Yes, that is pretty perfect, actually.
But what if you can't do this?
Then we got a problem.
Well, once again, if the patient can't tilt their head back all that far, we can make up the difference with tube angulation.
Okay, so we have perpendicular to the
I
IOML.
keep trying to read, and I don't have my glasses on. I'm like, okay, blur.
Okay, perpendicular to the IOML.
Okay, so you've got the patient's IOML parallel to the image receptor?
I don't know.
That's the.
Well, I'm asking, because you're standing right
That's
there.
the
You can see and I can't.
under, thing.
Exactly, the inferior aspect of the orbit.
Fancy words right there.
So right there.
Oh, now, okay, your centering point is off, and I'm going to show you why.
Yeah.
Okay, whenever you're lining this thing up, hang on, let me just make sure that we're pointing. All right, Ms. Jen, are you doing okay there?
Yeah, you can relax.
You look like you're about to die. I think she's getting woozy.
It's the light.
Okay. All right, super. Now, what I want to do,
Great.
I can't really see her IOML, but it looks like her. Okay, what I want you to do is take a step forward. Okay, take a step forward now. Lean back.
Oh my gosh, that's horrible.
There you go. Okay, that's real good. Okay, now, Mr. Ben, check this out. Your central ray is going to enter below the patient's chin, and it's going to. What you're going to do is you're going to. I think according to the book, it's like 1.5 inches below the chin. But the way you can check and see if you've got your central ray correct is it should pass through the EAM.
Oh, okay.
Oh.
Or, I'm sorry, like 1/2 inch above the EAM.
Okay.
Like right there. Okay, fantastic. All right, and we've got and we should see like the outline of the patient's nose. Now,
Yep.
we can't really see that because she's got this mask on.
Mm-hmm.
Not a problem. Okay, here we go. Down, down, down. Right about there. Okay, Ms. Jen, can you hold that position for me? Mm-hmm. All right, marker, shield, shoot. All right, you can relax.
Okay.
Thank you very much
Yeah, that's
for your participation in the SMV,
Alrighty.
submental vertex.
Submentum vertex.
Yes. Now, the cool thing about this image, and you're probably thinking, well, why in the world would we do this? A couple of different reasons. Number one, if there's a crack in the top of the patient's skull, we should be able to spot it. And we can also see the foramen. There's like a ton of little holes in the base of the skull that nerves and blood vessels go through.
Yep.
Like there's a foramen ovale and stuff like that. Okay, only on the SMV will we be able to see those.
Gotcha. Alright.
All right.
This is our 93.
Perpendicular
So settle 90.
Okay, let me see. There we go, that's better.
That was 91. Yeah. Okay. That. Now, so the OML is going to be perpendicular to the IR.
Quite true.
So, and it's going to exit the glabella, which is what I really need to focus on. So, that's exiting the glabella. And how shall I, okay, so can you put your forehead up against the IR? Yep. Perfect. There you go. Sorry about that. So, it's exiting the glabella. He looks pretty lined up east and west, north and south. PA 10 by 12 lengthwise. Alright, so marker lower right hand side.
Mm-hmm. It's going to be out of the way.
And I can collimate. Mandible can cut off, but I need the very top.
Correct.
So, I really don't want to risk that. I think he's good there. So,
Can't you call me here?
yeah.
Side to side, just, yeah, a little bit.
Yeah. All right, and that's it.
Okay,
Should be
so we
any
should
thoughts?
be able to get a skull, his skull on there.
Everything.
Okay.
Oh, well.
All right.
Okay, now from this side, I was able to see the OML,
Yeah.
and you did have it pretty much perpendicular to the image receptor.
Okay. And I can ensure that if it's exiting the glabella, right?
The glabella is just like, it's kind of like right between the
Yeah.
eyes, yeah.
So if the
whole
CR is exiting that, I can ensure that I have the OML perpendicular to the IR. Yeah?
Well,
Yeah.
kind of a no, because you could still go through the.
Yeah, exactly. You
without
could, your image
Bottom.
receptor could be too high or too low.
Gotcha.
That's a possibility.
Okay.
Shoot.
learn these lines. Make
Yeah.
sure you know the lines and use all of bits of information to line this up.
Oh yeah, something else I was going to show you guys. Now this is not in the sheet. Let me see, who can I victimize? Ms. Madison. Why me? Okay, Ms. Madison, if you wouldn't mind, step right up to the image receptor and put your face against this board. And as far as you know, I wiped all the COVID off of it. Okay, so forehead against the board, please.
Not the new strain.
There we go. Yeah, it's like, okay, what the heck? Okay, just as we're about to get vaccinated for COVID, all of a sudden they're like, oh, well, wait, now there's a new strain. I'm like, okay, well, does the vaccine work against the new strain or not?
Hasn't there always been multiple strains?
Or
Or that's always been the question about if there were?
Yeah.
I think most of the people that are talking about this trash don't know what they're talking about. You know, they're just winging it.
That's all they can do at this point.
Okay, now, am I open to 10 by 12?
I think
Yes.
so, yeah.
Basically. Wait a minute. Perfect. 10 by 12. All right, now, I'm exiting on the Caldwell. I'm supposed to be exiting the Nasion. So
Yep.
what I'm going to do is throw some angulation on this thing. And let's
15
see.
bottle.
Let's see. 90, 75.
85.
What?
No,
75.
75.
All right, you're going back to math class.
Okay.
She said okay.
Okay, Caldwell.
Yes.
Now, what, and stay right there, Ms. Madison, don't move. Okay, suppose that I'm trying to do a Caldwell view, but except for the doctor specifically wants air fluid levels.
Air fluid levels. Okay.
Okay, how do I demonstrate air fluid levels? Did we do the lab together where we were checking to see how much angulation you could get away with and still
I
show an
think
air
so.
fluid level?
That sounds familiar.
And I think it only
Yes,
wound up being like
yes.
10 degrees, and even then it was pretty iffy.
Yeah.
Okay, it turns out that if we're going to do this here Caldwell, we need, and we're wanting to show like fluid levels in the sinuses, then what we're going to do is actually use perpendicular central ray.
Yeah.
So I'm going to rock this thing back to my 90-degree position, and then bring it on down, 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 like so. Okay, now I'm still going to be exiting the Nasion, but remember how I had the 15-degree angle on there? Now what I'm going to do is I'm going to get my patient to rock their head back 15 degrees approximately. There we go. That's real good. Now it just so happens, okay, get right up
Lean
there.
that far forward.
Okay, now it just so happens that if you tilt your patient's head back, okay, like if you tilt back to the IOML, that's about 7 degrees. If you tilt back to the NML, that's like the point of the nose and the meatus, that's going to give you about a 15-degree angulation. So if you've got the patient's nose in line with their ear hole, then you've got you a Caldwell right there with a perpendicular central ray, and so you'll be able to see fluid levels.
Gotcha.
Yeah, that'll work. So this is another way to do Caldwell. Make sense?
Yes.
Oh.
Okay, outstanding.
So we're getting rid of the
Am I done?
angle and we're just
You can relax, Ms.
adjusting
Madison.
Patient's head.
the head.
I think you need more dizzy.
And get a perpendicular CR, which will give
Yeah.
fluid levels. Okay.